Today we're going to discuss the basics of high flow oxygen therapy, go over the indications, how it works, how to set it up, how to titrate it, and essentially how to discontinue it in your patients. So high flow systems are fairly simple. They basically consist of 6 basic parts. So we have our flow meter, which is connected to air and oxygen, and on some systems only oxygen. We have a flow meter here, which we use to control our basic flow, total flow to our patient. We then have an air and oxygen blender, which mixes our oxygen coming out of the wall and air coming out of the wall or through the bottom of the blender. And that allows us to set a specific FiO2 of the flow of gas heading to our patient. We then have an active humidifier down here below. Usually on most models it's the basic Fisher-Paykel with a heated wire and then a temperature probe proximal to the patient. That's just going to provide us with heat, and then we have a heater dome that's disposable and goes in the bottom that's then filled with water. So that's our basic humidifier there. We then have our heated inspiratory circuit, which then attaches to our interface. These are usually heated wire circuits to prevent too much condensation. We can have nasal cannula interfaces. We can also have tracheostomy interfaces as well. So it just depends on your manufacturer. So what does a high flow system provide? The biggest thing that it provides over low flow oxygen systems is flow. So we turn up the flow to exceed our patient's inspiratory flow demand. So a resting normal adult has an inspiratory flow demand when they're taking a breath in for basic minute ventilation. Every time they take a breath in, it's roughly about 30 liters per minute, right? When we have patients in duress, their minute ventilation is higher due to their high respiratory rates, their huge tidal volumes. They're taking in these large tidal volumes to try and compensate. When they're doing that, their inspiratory flow demands shoot up. So if you have a COPD coming in with an exacerbation, we could see inspiratory flow demands of up to 120 liters per minute. So what we do is we turn up and try and match their inspiratory flow demand. That way we can set a fixed FiO2. So if our flow demands are being met, we know that all the gas that the patient is inhaling is at that specific set FiO2 that we set on the blender. It is important that we try to match that as much as possible to the patient, okay? It also provides humidity. So when we stick a patient on just a 6-liter nasal cannula, the problem is it's dry air, right? You get problems with nosebleeds. It's not comfortable for the patient, and it actually reduces mucociliary clearance, right? We're drying out the mucus and the mucous membranes within that patient's nasopharynx and in their conducting airways. So humidity is super important. Along with humidity comes temperature. We try to keep it around body temperature, about 37 degrees, and that's more comfortable for the patient, and it also allows us with this higher temperature to have a 100% relative humidity depending on your system. Now, the biggest thing along with this flow is this connection to reducing anatomical dead space. So there's been tons of studies out there over this, but the concept is we're shooting tons of flow into the patient's nasopharynx, right? And when we do that, we're washing out their conducting airways. So any CO2, any dead space within, or any CO2 within that patient's dead space, right, is being washed out by this air-oxygen mix that we're shooting into their conducting airways. So it reduces the amount of rebreathed CO2. It also provides a reservoir of oxygen in the upper airway, and that can essentially reduce the patient's work of breathing. It reduces their perceived dyspnea. And yeah, it's super helpful. It can also supplement their inspiratory flow, so it can help them feel less dyspneic as well. So what are our indications? So the basic indications are just like any other normal oxygen therapy. So documented hypoxemic respiratory failure, so we may get an ABG, but primarily we're just going to see this patient come in probably to the ED on a non-rebreather. They're going to have lower SATs. They're going to have this high work of breathing, either from pulmonary edema or carbon monoxide poisoning, or they may just have just general signs of tissue hypoxia. So we'll stick them on heated high flow nasal cannula to make them more comfortable and reduce their work of breathing, reduce the amount of CO2 that they are rebreathing as well. There's other indications. So you have a patient coming in with pulmonary embolism. You have the pulmonary fibrosis patient who's having a exacerbation. Sometimes we'll give this to patients who have aspirated either gastric contents or but they're still protecting their airway. Or this is also huge in COPD exacerbations, right? Because we're able to reduce the amount of CO2 that the patients are rebreathing, try and get their PA CO2 down. Bronchiolitis is also another indication in children, but that's a whole different discussion. There's tons of pathways out there, but we'll primarily just talk about adults in this case. High flow nasal cannula is also huge in post-extubation patients, right? So anytime we're extubating that patient who is on higher PEEPs, higher FiO2s, we can possibly just stick them on a heated high flow nasal cannula after we extubate them. And this is a nice alternative to just traditional BiPAP or CPAP because you potentially have better compliance, right? So it's more comfortable for the patient. They can speak, although it's loud. They can speak. They can eat. We may want to turn down the liter flows when we're giving medications, but we can give medications via mouth. And then it's also great for procedural oxygenation. So we can do bronchoscopies while they're wearing the nasal cannula if we're going through the mouth. It's been used for pre-oxygenation during rapid sequence intubation or for support during procedural sedation, supine positioning for lumbar punctures, etc. So tons of indications for this, and it's certainly more comfortable than some of the alternatives. So what are our initial setups? So I'll outline the initial setups here, setup steps here. I'll have a video at the end of the presentation going over how to actually set up the device itself. So step one, we're basically going to assess the patient history and check for a history of COPD. The point of this is basically just to figure out whether we want to target a specific SAT, right? So in our COPD patients, we may not want to go up on our FiO2 as aggressively just because we can get some reversal of hypoxemic pulmonary vasoconstriction. So target SATs of 88 to 92, somewhere around there, instead of just our non-COPD patients where we're at about 90 to 95%. We'll start at a flow of about 40 to 60 liters per minute. Honestly, 60 is high. It's going to be uncomfortable for the patient. But start at the higher flow rates, especially if the patients have a huge work of breathing. If their respiratory rate's high, they have tons of nasal flaring, intercostal indrawing, suprasternal or supraclavicular retractions, just that huge work of breathing. We'll start high on our flow. We can titrate it back later. But that'll allow us to reduce their work of breathing the most, really flush out that CO2 to prevent rebreathing, and help reduce their dyspnea and set our FiO2 more appropriately. So after we set our flow, we can then titrate our FiO2. So we're going to watch our SATs, maybe later get an ABG if it's indicated, And then we're just going to continually monitor the patient. We recommend that you watch them stabilize for at least 15 minutes while you're doing your other treatments with them, other medications. And then once they're kind of stabilized, we'll do a 2-hour check, and then we'll do Q8 checks. And then once they're pretty well stabilized, we can start weaning back their FiO2. So we'll keep the flow up, but once they were able to drop down their FiO2 to about 40%, some protocols say 50%, we can start dialing back their flow a little bit. So as far as titrating settings, we'll come back to this concept of inspiratory flow demand, right? So in order to deliver a specific FiO2 that we set, we need to be providing all the gas to the patient, so they're not inspiring and entraining room air and lowering our fraction of inspired oxygen. So if the patient's got a high work breathing, turn up our flow. That'll allow us to set a more fixed FiO2. I went over the normal inspiratory flow demands. Just realize that if they're normal tidal breathing in most adults, it's about 30 liters per minute. So we can increase our flow based on changes in the patient's respiratory rate and breathing pattern. So if you come back for your 2-hour check, or your RT comes back for the 2-hour check, and they notice that their work of breathing is higher because they maybe missed albuterol treatment, etc., we can turn up our flow and potentially start back over and go from there. So we should always titrate our flow before modifying our FiO2, though. That's generally going to lead you to more success. Weaning. So this is kind of a big controversial subject that's not super well studied, but in general, once the patient's condition is stabilized and rapidly improving, we can start dialing back our FiO2. Again, once we reach about 40 to 50%, we can start lowering our flow, generally incrementally by 5 to 10 liters per minute, right? If the patient uses home oxygen, we're going to wean them down to that documented liter flow. So once we get down, let's say they're on a liter flow of 4 liters per minute of oxygen at home, we can drop them down on their flow and turn up the FiO2 to 100%, right? And what that'll do is we can dial back our flow all the way down to 4 liters per minute on some devices, and we can basically just act like they're on their liter flow at home. Eventually we'll just switch them over to a traditional nasal cannula after they've stabilized for a little bit, but we're going to incrementally do that either during our Q4, Q8 checks. So do not continue weaning the patient, so dropping the flow or the FiO2 if their pulse is labile, or there's presence of EKG changes. They start getting more and more confused. Their tachypnea gets worse, or they currently have a high respiratory rate. And then again, just monitor your SATs. And then we're going to reassess our patient 2 hours actually after we discontinue our high flow, just to make sure they're doing okay on our low flow oxygen systems. So I'll have Kelly go over the basic high flow system setup here. We filmed a video on how to do that if you are interested. Otherwise, please reach out to us. Joe Coyle, who's our department head at Boise State University, is great at answering our questions, and he can be reached at this email right here. I'll pull it up on the screen, and we'll kind of go from there.
Hi, so today we're going to be setting up the air oxygen blender. So first you start by taking your heater down, taking off the cap, and then pulling this back and putting it on top of the heater. That way you can get humidification. And then you will attach the longer blue tubing into one of the sides. It doesn't matter which port you put it into, you can put it into either side. Next, we're going to take our high pressure release valve and put that on the other side. Next, we're going to take our oxygen tubing so we can hook up that high pressure release valve to our oxygen. Making sure you have a tight seal. And then next we're going to take our heater probe. Our heater probe allows us to heat the water going through and give us humidification. They come in a sterile package just because the tip of the heater probe is what will be making contact with the air that the patient is rebreathing. So you hook it right down here into the bottom blue port. And then right here you're going to pop off the cap and then put this in, and there's a little V right here, and you want to match it up, and you're going to hear a click. So once that click is in, you know it's in place. And then you'll see this 3-pronged one that's going to fit right into here. And that's all just connecting the heater down up. And then you're going to thread this up and around. And attach the sensor to the end of the tubing. And then you can just secure everything in place. Get a cap to put on the end. And that's just the basic setup. Alright, so the first step you want to do after you have all the setup done is you want to hook up your oxygen and your air. You may hear a loud kind of ringing noise at first, and that's just going to happen until you have both of them plugged in once it's turned on. So I'm going to go ahead and put my oxygen. You'll hear that noise. And now it stops. And then the last thing you need to plug in is the cord which powers the heater dome. Alright, so now it's on. So we're going to turn this on just by holding it down. We're going to set it to non-invasive. We'll just pretend that we are going to be ventilating a patient on a nasal cannula. And then so first we want to set our oxygen to 30, and then we're going to titrate our FiO2 based on the patient's oxygenation. So if their SpO2 is 80, we want to try and adjust this to get a SpO2 of 90%, so we can adjust as needed. And you just want to sit and kind of wait and watch and monitor your patient to make sure they've kind of stabilized around that area. So this is the high flow nasal cannula that is used most often. It comes in various sizes, around small, medium, and large. This one is a medium. And so all you have to do is hook this piece up here and then just pop it on the end right here. And then you're also able to clip this to the patient's shirt or anything if needed, so that nasal cannula can really stay in place.